Hi, I'm Dr. Flanagan. I'm an anesthesiologist who specialized in chronic pain management, and today we're going to talk about some of the most common causes of lower back pain. So we'll look at the anatomy of the lumbar spine, discuss the causes of lower back pain, and the typical treatment options and goals. So lower back pain is one of the top 3 reasons people visit the doctor. About 25% of adults have at least 1 day of back pain in 3 months' time. So it's a pretty important topic. If we look at the anatomy, you have 5 lumbar vertebrae, intervertebral discs between each vertebrae, facet joints that connect the bones on the back side of the spine, lumbar nerve roots that leave the spinal cord to enter the body, and then below that, the sacrum and the ilium, which form the sacroiliac joint. So just so you can have an understanding of what all that is, if you look at the picture here, you can see the pelvic ring. The pelvis is small in the front, and then it flares out as it wraps around into the back, and it grabs onto the triangular bone called the sacrum, making the sacroiliac joint. Above that, you have the vertebral bodies, and each vertebral body connects to the one above it and below it at the facet joints. Between the facet joints, at each level, there is an opening on each side where one nerve is allowed to leave the spinal cord. That opening is called the neural foramen, and the nerve root is what leaves at that space. So causes of lower back pain, you have facet arthropathy, which is just a fancy way of saying arthritis of the facet joint. You have sacroiliac dysfunction, which can be arthritis or other causes of pain from the sacroiliac joint. You have nerve root impingement, where there's pressure in that neural foramen on the nerve root as it's trying to leave the spinal cord. Annular tears, which are tears in the disc itself. Muscle imbalance, where the musculature of the lower back has been injured with a sprain or strain. And then disc herniation, where the disc has had some kind of injury to it and is now pushing out, usually into the spinal canal. Treatment options for lower back pain depend on time and whether it's an acute, subacute, or chronic injury. So an acute to subacute is anywhere in the last 1 to 3 months. Once you've had pain longer than 3 months, the injury is considered chronic. There's interdisciplinary rehab for chronic pain, which we'll get into in a second. That includes exercise, yoga, massage, and then we also have medications. So if you look at the treatments, when you first injure yourself, it's recommended to do treatment options such as heat, because it dilates blood vessels, bringing helper cells to the area. You can also do cold, ultrasound, TENS unit, traction, ionophoresis, which is another interesting treatment modality where they actually use a battery to force a charge into a pad of medicine, which then forces the medicine through the skin to the area of injury, and then supports and braces, which are usually not recommended most of the time for back injury, because when you use a brace, the muscles end up getting weaker and then you develop more pain. However, in certain instances, a brace may be beneficial. There are also psychological therapies, which are done at physical therapy, and alternatives like manipulation or chiropractics and massage or acupuncture. Other treatments include medications. When you first injure your back, they recommend over-the-counter medications like NSAIDs or acetaminophen, which is Tylenol, topical agents like lidocaine patches or Salonpas, neuropathic agents, which just help calm down the nerves if they have pressure on them, and sometimes even antidepressants. Once you have pain for a while, you can get symptoms of depression. It's very common. Depending on the cause of your pain, you can also benefit from muscle relaxers, oral steroids, interventional spine treatments, lidocaine, ketamine infusions, and opioids. So when you look at these medications, NSAIDs have increased adverse effects compared with placebo and acetaminophen, because NSAIDs themselves can damage the kidneys as well as the lining in the gut. So oftentimes over age 65, NSAIDs are not recommended for long-term use. If you're going to use them for a couple of weeks and you don't have any kidney problems, then usually it's acceptable. So if the acetaminophen or Tylenol isn't helping, then a lot of times people discuss opioids. The problem with opioids is that, one, they're a controlled substance due to their addictive nature. They can cause nausea, dizziness, vomiting, constipation, dry mouth, hormone changes, as well as many other side effects. Benzodiazepines is another medication that has been used in the past, mostly for its muscle relaxing effects, but due to its addictive nature now, it's fallen out of favor. It also can cause respiratory depression, which is another side effect that made it fall out of favor. And then the antidepressants. Oops. Did I do that? So the American College of Physicians recommends that most people who have acute to subacute pain, it will improve with time. I believe the last study I read said 83% of lower back pain gets better with physical therapy. A lot of times when you first injure your back, physical therapy is recommended, as well as some type of anti-inflammatory. For chronic lower back pain, so lower back pain that you've tried physical therapy and it didn't improve with some help with anti-inflammatories, then we move on to the other treatment options. So as far as interventional treatments, there are a couple listed, and we'll talk about all of them. So you have epidural steroid injections. So I have a model here. If you look at this, an epidural steroid injection is a steroid injection, so a non-steroidal anti-inflammatory is like ibuprofen or Aleve. A steroid is also an anti-inflammatory, but it doesn't have the kidney or GI issues. And an epidural would be used if you're having pinching on the nerve as it's trying to exit the spinal canal and go to the legs from the lower back. Basically what an epidural steroid injection does is, is we sneak a little needle using x-ray under the bone here into the neuroforamen and inject the steroid to get rid of any inflammation in the area. Facet joint injections also use x-ray, and we basically have you lay on the x-ray table and line up the x-ray so that we can see the facet joint where it's open, and we put a little needle into the facet joint itself, and again we inject steroid and some numbing medicine to get rid of any inflammation in that joint. Some people get great relief with facet joint injections for a long period of time. Other people, it's only short-lived. Facet joint injections are usually used for more acute pain because when you first injure yourself, your body says, oh my gosh, I'm injured, and it sends blood and helper cells to fix the injury. But that causes the inflammation. And then you have all this pressure from the inflammation, so you need an anti-inflammatory to get rid of that pressure and inflammation from the joint. And that's why a facet joint injection helps. If you end up going to chronic pain and you don't get rid of the back pain, there's another option for pain from the facet joints, and that would be a medial branch block. What you do with a medial branch block is we have you lay on the x-ray table and we go down with needles and we numb the nerve that innervates the facet joint. The numbing medicine that's used only lasts a short amount of time, and it's just a diagnostic test. What it does is it tells us, does the pain come from the facet joints, or is this pain coming from the muscles or the disc or somewhere else? So if you get good relief with a medial branch block, you're a candidate for another procedure called a radiofrequency ablation. Radiofrequency ablations do the same thing in that we use a needle and we lay it where the nerve sits and we heat the area up. When you heat up that area, it causes proteins on the nerve itself to change shape so that the chronic pain signal can no longer get to the brain. Over time, your body can figure out that those proteins have changed shape and it can put them back. If that happens, the pain returns, but we can always repeat the radiofrequency ablation. Most people get relief from a radiofrequency ablation for about 6 months to a year. Next on the list is a sacroiliac joint injection, which is similar to a facet joint injection or any other joint injection. Basically, we use the x-ray to see where the sacroiliac joint is open from the pelvis. We inject steroid and numbing medicine into that joint to calm down any inflammation. Now, when braces come into play, like I said before, is when you have a compression fracture. So as people get older, they're at risk for osteoporosis, osteopenia, and they can actually have weak bones that can break, causing compression fractures, which means that the vertebral body itself breaks, and so instead of being this high, it's now shrunk down because there's a fracture in here. So this can be treated a couple of ways depending on the type of fracture you have. One of the ways we treat it is with a brace. So a brace around your mid area when you have a compression fracture is similar to putting a cast on your arm when the bone is broken. However, when you have osteoporotic bones, they probably take longer to heal, and so you also would probably require pain meds for however long that takes. Sometimes the bone doesn't heal, or the pain is so excruciating that the brace doesn't help, and you can have what's called a kyphoplasty. For that, we use x-ray as well, and we have a needle that we put through the backside into the bone, and we inject bone cement. Once the bone cement is in there and hardened, the fracture is no longer there because the bone is basically cemented back together. Last but not least of the things we were going to talk about today would be a spinal cord stimulator. Spinal cord stimulators at first were only recommended for people who had had lower back surgery and did not get good relief, called failed back syndrome. But now they've also been approved for other things like peripheral neuropathy from diabetes and radiculopathy with pain radiating down the leg for other causes. What a spinal cord stimulator is, basically we use needles and we place 2 leads into the epidural space, the same place you would put catheters in for a pregnant patient in labor. And we use the x-ray to thread those leads up into the thoracic spine, where all of the chronic pain pathways come together posteriorly on the spinal cord so that we can use the electricity to block the pain centers and generators from getting to the brain. We tape a battery to your back and you try it out for a week. If you get good relief, we can then reschedule you and have it implanted under the skin. So whether you get good relief or not, after that week, the device comes out because we don't want you to get an infection. But if you do get good relief, then you would be scheduled for an OR visit where we would replace the leads in the same place, but instead of just letting them sit, we actually put an anchor and tie it to a membrane that sits between the vertebral bodies, the spinous processes here, so that when you bend, it pulls from the back and these stay in place. Then we tunnel it under the skin and you get a little battery that's placed in one of your flanks, kind of like a pacemaker battery. The batteries usually last 8 to 10 years. That's all we have. Does anyone? So you can come see us anytime you have pain, but most of the time it's more beneficial if you first see your primary care doctor if you have acute pain. So if you fall or injure yourself in a car accident, a lot of times the insurance companies won't cover anything until you've tried over-the-counter pain medications and physical therapy. So we recommend that, or I recommend that you follow up with your primary care physician to be evaluated first, so that you can start physical therapy, maybe get x-rays, and start on pain medications for over-the-counter or maybe a muscle relaxant to see if that improves your pain before you even have to bother coming to see me. So women tend to have more pain in the SI joints just because of the laxity in the joint, because we're built to bear children, where men are not, but otherwise, not really. Back pain is more of it can be genetic, so if your parents had back pain, you're lucky enough to probably end up with some kind of back pain. If your parents have arthritis, you're probably lucky enough to end up with some kind of arthritis, but it also depends on wear and tear. So if you were in an injury, in a car accident, you're more likely to have back pain. If you do heavy labor for a living, if you don't use proper lifting procedures, then you're more likely to have back pain of some kind. Like I said, the last study I read stated that 83% of back pain in the United States, people who complain of it in the United States, can be fixed with physical therapy and over-the-counter pain medications. So when you have stenosis, that's tightening of the space around the nerves. There are different types of stenosis. So there's central canal stenosis, and then there's neuroforaminal stenosis. So if you look at this model, the central canal is this part here, and it goes from the base of your skull all the way down. Basically, the way you're built is you have these vertebral bodies, and then each vertebral body puts out this bony bridge called the lamina, and then those connect at the facet joints. What that does is that's what makes the canal for your spinal cord to sit in. And then the neuroforamen is the opening, allowing your nerves to leave at each level. Whoops, this one's broken. But you get one nerve, usually, at each level to leave. So if you have stenosis, it depends on the cause of the stenosis. A lot of people have bulging discs as they get older. That doesn't mean you'll have pain from the bulging discs, but then if you're in a car accident and the bulging disc gets flared up and you have inflammation, then the treatment for that would be an epidural, where we inject steroid into that area to get rid of the inflammation. However, if the stenosis is from bone extrusion or a disc that's ruptured, a lot of times an epidural won't give you long-lasting relief, and then you may require surgery to fix it. I don't know how you would know. It would be mostly it comes down to your symptoms as well as your imaging. So on imaging, you can have both arthritis and stenosis, but you may only have pain in your back. Most of the time, that's considered what we call axial back pain. Most of the time, that's from arthritis in the facet joints. That pain would be worse usually when you bend backwards because you're grinding those facet joints, or with twisting, loading and emptying the dishwasher, sweeping floors, vacuuming, those types of movements. A lot of time arthritic pain is worse in the morning because those joints have become stiff, and as you move throughout the day, you have a lubricant in those joints that helps grease those joints, but then if you overdo it during the day, you'll have pain again at night. Stenosis most of the time causes radicular symptoms, where what that means is you get pain down the length of the nerve that's being pinched or has the pressure on it. So if you put pressure here from stenosis, then you'll have pain that radiates down your leg in the nerve's distribution. So when people come in and they complain of that, and their MRI findings show they also have stenosis at that level, then most likely their pain is coming from the stenosis. Whereas if people have lower back pain only with no leg symptoms and they have stenosis and arthritis, most of the time their pain is coming from arthritis. But that's why we do the diagnostic blocks to see, is it coming from the joints or is it coming from somewhere else? Probably the best things you can do to help avoid getting lower back pain would be to have a strong core. So your core muscles include your abdominal muscles, your pelvic floor muscles, your lower back muscles, and your muscles, your transverse muscles, the muscles on the sides. So exercises that strengthen those would include bridging and planks, as well as other core strengthening exercises, but bridges and planks are the most, I think, basic of those. The causes? Wow, I feel like there's a lot of causes you can have pain there. So anytime, so your sacroiliac joint is an interesting joint because it's huge, actually. It's one of the largest joints in your body, but it doesn't move very much. So your pelvis actually grabs on both sides to this triangular bone called the sacrum. Your tailbone hangs off the end. And your sacrum twists back and forth. It rocks forwards and backwards, but it does it very small movements. So any type of jarring effect to that, so a car accident where you're rear-ended or hit from the side, which could cause a torque in the sacrum, or the sacrum to be put forward or backwards, stepping off the curb and not realizing there was a curb and having that moment, that can cause a shearing of this sacroiliac joint. So there's lots of different causes that you can have sacroiliac joint pain. You also have a small muscle. You have your glutes, of course, but then you have a small muscle called the piriformis muscle that sits, it's about the size of your thumb-ish, and it sits across the sacrum and the ilium. And you can have a problem with that where you can either have muscle spasm or muscle weakness in one side or both, and that can also cause SI joint pain. So spondylosis simply means that your vertebral body has slid. You have arthritis in your facet joints, allowing your vertebral body to no longer line up exactly the way it's supposed to be. So there's like room back here in the facet joints, allowing movement of one vertebral body on another. So depending on the severity of the spondylosis, some people need a fusion. Other people, if they just have some lower back pain, can strengthen their core and do radiofrequency ablations to help with any pain from the facet joints. Those are the two most common treatments for pain from spondylosis. If you want to talk about how to treat it, that would be a surgical question. Most of the pain questions, we don't fix those problems. We just help you manage them so you can continue to live, but we don't fix any of those issues. Sciatica simply means radiculopathy of the sciatic nerve. So your sciatic nerve is your L4 and your L5 nerve. They exit the spine separately, but then they come together and they travel down the back of your leg together as the sciatic nerve, and then they split again once they get further down your leg. So if you have any radicular symptoms down the back of your leg, that can be referred to as sciatica. Radiculopathy in general is nerve pain in the nerve's distribution. So nerve pain is usually described as numbness or tingling pain, burning pain, electrical pain. Those would be examples of radicular pain. Sometimes you don't. Hip and back pain can be confused very easily. Most of the time, if you have hip arthritis, your pain will refer somewhat into the groin in the front. So that's one of the ways you can distinguish between one and the other. Another way is to have an exam of the hip, where we actually grind the hip in the joint by flexing and internally rotating the hip, which causes the hip to grind into the joint of the pelvis. And if you have pain in the groin with that, that's another reason you may have hip pain. But you can have all different kinds of hip pain. Hip pain, if you have tenderness on the lateral aspect of the hip only, you have a bursa that sits there, that could be inflamed. We do an injection to treat that. You have your tendon that travels, your IT band travels from your hip down to your knee, so it's difficult to distinguish whether it's IT band pain or radicular pain from your back sometimes, so you would need a physical exam. Back pain a lot of time refers down into the buttock and the hips. So again, if it's from the back, a lot of times facet loading or causing, when you arch backwards, if that makes it worse, more likely it's coming from the back. But to distinguish whether it's the hip or the back, you would need a physical exam and imaging of both to determine which one it is.